My name is Kim Hendershot. I am a trauma surgeon at UAB in Birmingham, Alabama.
Fantastic. It's nice to meet you. My name is Audria. I'm an MS3 or almost MS3 here from AWS, here to interview you. Could you give us a little bit more about your title and what department you work in?
Yeah, so I am in the Department of Surgery. I am a trauma surgeon. And so what that means is I went through 5 years of general surgery training. And then after that, I wanted to pursue additional training to be a trauma surgeon. Most people that do trauma surgery have to do at least 1 year, but some people do multiple years to become a trauma surgeon because basically as a trauma surgeon, I can do trauma. And then my fellowship is in trauma and critical care. So I can also do surgical critical care, which is basically doing all the ICU care for surgical patients. And then most trauma surgeons, because of our general surgery background, we also do what's called acute care surgery, which means taking care of patients with emergency general surgery conditions. So that kind of came about because trauma surgeons were in the hospital all the time. And it was like, people would show up with appendicitis or some other surgical condition. And it was like, well, the trauma surgeon's just right here and they're a surgeon too. And so a lot of people that do trauma do a combination of all of those things. So do trauma surgery, do emergency general surgery, and do surgical critical care. And so we kind of encompass all that into one term called acute care surgery.
Fantastic. Thank you. So I believe our next question is talking a little bit more about that journey. You mentioned you had to do a fellowship. Was it just one or is it two? Or does it vary in the length?
It is variable. So in order to become a trauma surgeon, you can do 1 year of fellowship. You have to do 5 years of general surgery, but then you can just do 1 year of fellowship, which technically is a critical care fellowship. There's really no titled trauma fellowship. Now, there are some places that will do a second year where you get more of the trauma and some of the other subspecialty care, where you do like rotations, with surgical oncology to get, kind of more experience with, difficult injuries to manage. It just depends. You can do 1 year, you can do 2 years. I also did a year of research, which some people do while they're in their surgical residency. I chose to do mine afterwards and kind of focus it more on trauma.
Okay. Can you tell me a little bit more about your journey, whether that's into academia versus just I guess that decision making?
Yeah. I think, I grew up with a nurse as a mother. And so I went to college kind of knowing that I wanted to do something in the medical field. So kind of took the traditional, biology, chemistry, all of those courses in college. And it was really in medical school. Honestly, when I went to medical school, I kind of thought that I was going to be a family practice doctor. I thought I would just, practice in a small town and be kind of a small town community doctor. And during medical school, we had opportunities between our quarters to do to kind of shadow people and do kind of we called them selectives because you got to select which ones that you wanted to do. And for some reason, I just gravitated towards the surgical ones. And so I did a couple of those and was kind of like, oh, these are interesting, but still kind of thought like, well, I probably, I don't think I want to do surgery. Um, and then during my third year of rotations, I did a surgery rotation and I was like, wow, I love this. I think it was, the kind of very streamlined, logical thought processes. um, I and so um, I really, was drawn to it. But honestly, I was a little scared because people all around me were kind of saying, like, oh, the lifestyle's terrible. You don't want to be a surgeon, all of those sorts of things. And um, so then at the end of my third year, because I took surgery as one of my like last courses, because I didn't think I wanted to do it. So at the beginning of my fourth year, I said, well, what I'm going to do is I'm going to take the hardest acting internship that the hardest surgical acting internship that we have. Like, I'm going to take that, to like really figure out if I want to be a surgeon or not. Um, because if it's so hard that I hate it, like that'll just answer my question. And it happened to be a trauma rotation at like the inner city metro hospital that we had. And I just absolutely loved it. So it was that point that I was like, I don't think I can do anything else, now that I know about this love of surgery. Um, so, that kind of like a little bit changed my trajectory. And so kind of had to like, figure out what that looked like, and that sort of thing. And so, yeah, and so then, I did my surgical residency at Georgetown in Washington, D.C. And that was very interesting also. I'm from kind of a small Midwest town, and so kind of being in the big city, doing this was definitely very different. Um, and then during my surgical residency, I had several key mentors that really kind of embodied what I wanted to be as a surgeon. Um, and those people happen to be trauma surgeons. But looking back, I think like even in medical school, I always gravitated towards trauma and always liked a little bit of not knowing what the next thing coming in is going to look like. And just kind of the challenge of figuring out life and death situations when people kind of present to you in the emergency department, and not just being an ER doctor where I kind of figure things out and then I hand it off. It's like I want to figure things out and then I want to go to the OR and take care of it. I want to go, fix their problem and then follow them afterwards, and through that recovery period so that I can help them get better, and follow them up in the clinic where I see them getting back to their normal lifestyle and that sort of thing. So after my surgical residency, I did my fellowship at Inova Fairfax Hospital, which is located just outside Washington, D.C. And I did a year of trauma research because I just felt like I wanted to do some research. I wanted to, look into things and kind of understand how research is done and kind of get a better handle on that. And then I did a year of trauma fellowship there at Inova Fairfax Hospital, working with people. Again, it was kind of, we saw a lot of the inner city violence, but then just outside of Washington, DC, there's also, major highways. And so a lot of car crashes, a lot of construction accidents and that sort of thing. And so getting a large volume of patients with injuries, to really kind of test my skills and, kind of see a wide variety of injuries, is always a great place to do a fellowship where you're going to see a wide variety of things. And then, because most people do trauma as well as general surgery and critical care, I went where I did my trauma fellowship didn't have a critical care fellowship. So I then went to the Ohio State University to do my critical care fellowship. I'm born and raised in Ohio, so it was nice to go home to be able to do a fellowship closer to my family and that sort of thing. So, and then, and then I was ready to kind of go out into practice in the real world and, take care of patients.
That's a wonderful story. I'd love to hear all of that. You actually made me think, and this isn't on our list, but hopefully you don't mind. Do you feel like trauma surgery differs in the region that you're practicing, or is it all about the same depending on like a urban versus rural environment?
I think trauma is fairly standard across the country. I think you do see different types of injuries, though. Obviously, if you're more in a rural environment, I mean, here in Alabama, we see a lot of farming accidents, fair amount of construction accidents and that sort of thing. But obviously it is a little regional as far as what you're going to see. If you go out to, kind of, like Colorado, Wyoming, those sorts of things. I mean, you see more like, skiing, snowmobiling, those sorts of things. Some of the places kind of out west, you see more kind of wilderness, kind of survivalist kind of injuries. So it somewhat differs as to what you might see, but I think how you manage all those injuries is very much similar. You know, as medical students, we students here at UAB have the TEAM course, which is a national course that teaches about trauma emergencies and how to manage those. That's what it stands for, trauma emergency and management. And then as residents, they take what's called ATLS, which is Advanced Trauma Life Support, that really teaches like how to manage patients that are injured. And we've discovered that, kind of having a, kind of a common way to think about problems, leads to better care for patients when they're injured because, sometimes, if a patient comes into a small place, with a limb cut off or something, people might panic and really freak out. And you really need something to fall back on, which is like a basic algorithm for how to manage a patient. So, so you find that most trauma places manage things relatively similar. There will be some differences, but.
Okay. I'm going to go into our more standard AWS type questions.
Okay.
As a female surgeon, what challenges have you had and how did you overcome it? And then also,
I think I think as a female surgeon, you definitely have challenges. I think you have some challenges when it comes to proving yourself, sometimes to your patients. I've definitely had the experience of, walking into a room and, still the patients say, oh, my nurse is here. And so, trying to, then prove to your patients that are their surgeon, are competent, that sort of thing. When I was younger, obviously, you know, um, when you're young and look young, there's even that's for guys too, but like, when you are female and young, you kind of have those patients that, don't think, and they'll say, you don't look old enough to be my surgeon, and that sort of thing. Um, I think that you also have challenges, proving yourself to nurses and proving yourself to your peers, other doctors, and that sort of thing. So definitely as a female, you have to learn how to communicate effectively, especially with a group of female nurses. And so there are just some inherent challenges with that, that I think, if you are female and want to go into the surgical field, I think you will have the chance to meet many different mentors. But I think it is absolutely necessary to have at least one female surgical mentor, so that they can help you navigate some of those issues, or help you think about it would even be better if you thought about those in advance, um, for how you're perceived and how you come across. Surgeons are usually somewhat direct, and sometimes kind of no nonsense. I really want to, especially trauma, like I really have to get my message across, sometimes quickly, sometimes succinctly, and usually I have to be very direct. But that sometimes will grate on people, and then people will think that you're too abrasive and brash and that sort of thing. And so you sometimes have to kind of balance those issues out. So I think knowing that you need to do that, and knowing that you sometimes need to, um, you know, have, kind of softer conversations, and show some vulnerability and show some of your softer sides, I think, is, necessary.
Okay. I'll take that to heart and I'll practice it next year. Let's see. Also, could you tell us more about the balance between your professional life and your personal life?
Yeah, I think, I think, um, everyone wants to have kind of the best of both worlds. I mean, I think all of us want to be successful in our careers, but also want to have personal time, whether that's personal time being married, personal time having kids, or just personal time, being single and spending time with your parents, your friends, anything that you want to do. So really, I think you need to kind of take that into consideration when you think about what you want to do, and how you want your practice to look when you get done with things. I think one of the reasons that I chose trauma, um, is that I would rather actually be in the hospital on call, um, for 24 hours at a time. I mean, we take in-house call in the hospital, for 24 hours. And I would rather do that, because my family knows, okay, when I'm at the hospital, I'm at the hospital. Um, and so I would rather not, when I go home, be tethered to my pager, or have people call me when, I'm in the middle of watching my kid's soccer game. And I definitely would rather not have to leave that soccer game to come to the hospital to take care of an emergency. So I feel like my job, I have a little more separation of my work and my personal life. Um, other people are like, feel like being in-house is more like a resident. And so some people are like, when I'm done with residency, I just want to I want to take the in-house call, or, the home call, and not have to, be stuck in the hospital for 24 hours. But but those are all just things that you have to figure out what you personally want out of your career and what that looks like. I don't want my husband to have to wake up to my pager in the middle of the night and disrupt his sleep, and, wake my kids up when I'm trying to like get ready and get out of the house in the middle of the night or anything. And I don't have to do that because, I have, my partners that when I'm not in house, they're in house and they're covering everything. So that's just kind of the choices that I make. And for me, it works. But I think, no matter what you do, I think every specialty, including surgery, but not exclusive to surgery, every specialty, you're going to have, things that you miss. Honestly, you could be a family practice doctor, you can be a psychiatrist, and things will come up and you may have to miss certain holidays, or certain, family get-togethers or that sort of thing. What I try to do is I try to, in my mind, have my husband and I keep a joint calendar electronically so that I can tell the person making the call schedule, like, hey, I have an important event, at my kid's school on a certain day. So please don't put me on call that day, and that sort of thing. So I try to manage my calendar very um, judiciously and really stay on top of that, to try to miss the least amount of things that I can miss. But, I mean, it's the same for everyone. So, someone has to be here for Christmas and someone has to be here for Thanksgiving. But I have partners that I share that with. So if I have to be here for one holiday, then I'm off for another holiday, and they have to be here. So it's a balance.
That's great. I think I like that. The sharing the responsibility.
Yeah.
So we have a couple more questions. These are the more fun, short little questions. So what
Okay.
is your go-to OR music?
Well, it very much depends. Usually if I'm doing a trauma case, I don't have any music. So like, if a patient comes in and they're really sick and bleeding and things, usually we need, that ability to communicate very succinctly. So a lot of times in the trauma OR, and you'll find that a lot of trauma surgeons, like in the big traumas, won't have music playing. If it's more an elective case though, um, I'm kind of eclectic. I mean, I like all sorts of music. I like, pop and alternative music. Here in the South, you kind of have to like country music, but I already kind of liked country music a little bit. Um, usually I'm pretty open, and a lot of times I'll just let the resident choose whatever music they would like to choose because sometimes they don't get a choice. So they can choose when they come in the OR with me.
Fun. Okay. What about, I know sometimes with OR days it can be a little hard to catch a meal. So what's your go-to OR snack?
Yeah, I definitely in the mornings, like a kind bar. Usually, I like the dark chocolate peanut butter kind bars in particular. So those are are really good. Um, and a lot of times in my office, because sometimes I'm stuck in my office and I may be able to get back here to get a little snack or something. I keep a lot of different types of nuts, um, to get some protein, to not just be eating like candy and things, because there's so much like candy, donuts, junk around the OR. So, I try to reach for something that's healthier. I don't always succeed because sometimes those donuts just look too good, but so I try.
Okay, what about hobbies? What hobby do you do outside the hospital?
Yeah, my husband and I, before we had kids, really loved to travel. And I think eventually when our kids get old enough, we can do that again. But and they're getting there. My son is 6 and he's in first grade, and my daughter is 4. And so she will be going in kindergarten, not this coming year, but the next year. So hopefully we will do more traveling when they get a little older and are able to do that, without the constant stopping for bathroom breaks every like 20 minutes.
Yeah.
But I do enjoy like just reading books for pleasure, you know, um, non-medical books. So, but a lot of my hobbies revolve around my kids these days. So as I said, both of my kids play soccer. My son played basketball and my daughter loves to dance. And so, their hobbies are my hobbies these days. So I try to support them in those.
That's awesome. I love the family focus. That is all of our list of questions. Is there anything else that you would like to discuss? Otherwise, I'll just ask for like one last thing.
Yeah, I don't think so.
Okay. So then our last takeaway for the interview is just what should we as medical students take away? Like what, if you could give us one last piece of advice, what would it be?
Yeah, I would say find whatever you're passionate about, whichever aspect of medicine that you're passionate about, and figure out a way for it to work in your life. You know, don't don't let kind of little obstacles throw you off. If you're really passionate about it, you can figure out how to make it work.
Thank you, Dr. Hendershot.